Hello everyone. The next developmental disturbances of oral lymphoid tissue I'll discuss in this video. The next developmental disturbances of oral lymphoid tissue, that is Angiolymphoid hyperplasia with eosinophilia, that is ALHE, and lymphoepithelial cyst. First is Angiolymphoid hyperplasia with eosinophilia, otherwise known as epithelioid hemangioma, histiocytoid hemangioma, pseudopyogenic granuloma, papular hyperplasia, inflammatory angiomatous nodule. Angiolymphoid hyperplasia with eosinophilia is an uncommon idiopathic condition that presents with isolated or grouped plaques or nodules in the skin of the head and neck region. Most patients present with these lesions in the periauricular region, that is present in front of the ear. In the picture also you can see there are some nodules which are present in front of the ear or preauricular region, forehead or scalp. It is marked by a proliferation of blood vessels with large endothelial cells. Sometimes these blood vessels are accompanied by a characteristic inflammatory infiltrate that mainly eosinophil. The name itself suggests there is an increase in inflammatory infiltrate of eosinophils. The etiology is idiopathic. Whether this is a benign neoplasm or an unusual reaction to various stimuli, that can be any trauma, it remains unclear. So whether these lesions are neoplastic or reactive, it is not known. But most of the cases, there is a reactive cause is more common. Coming to clinical features. ALHE has occurred following various forms of trauma or infection, like hyperestrogenic state, for example, pregnancy, after oral contraceptive use may cause lesion growth. The distinctive inflammatory infiltrate in ALHE appears to be an intrinsic, it is not a secondary component of the lesion, and approximately 20% of patients have blood eosinophilia, that is increase in the eosinophil, and it is uncommon but it is not rare and most commonly seen in females in the age group of 20 to 50 years. Patients with ALHE typically present with an expanding nodule or group of nodules, usually in the vicinity of the ear. The lesion may be associated with pain or pruritus. Uncommon symptoms like pulsation and spontaneous bleeding typically appears as dome-shaped, smooth-surfaced papules or nodules. In the picture you see the surface is smooth and it is present as nodules and dome-shaped in the ear region. Approximately 85% of the lesions occur in the skin of the head and neck. Most of them are on or near the ear or on the forehead or scalp. The lesions range from erythematous, that is red color, to brown in color, and it may be appear eroded or crusted. Approximately 80% of patients present with isolated lesions, that is single lesions, while the remaining 20% of patients usually demonstrate grouped papules or nodules in a single region. Rarely, the lesions may be pulsatile, and most of the lesions are 0.5 to 2 cm in diameter with a range of 0.2 to 8 cm. Larger nodules tend to be deeply centered within the subcutis. Differential diagnosis of ALHE can be granuloma faciale, insect bites, pyogenic granuloma, that is lobular capillary hemangioma, angiosarcoma, hemangioendothelioma, and hemangioma. Histopathological features of ALHE. Biopsy is required to establish the diagnosis. It shows characteristic histologic features including a proliferation of small blood vessels, many of which are lined by enlarged endothelial cells with uniform ovoid nuclei and intracytoplasmic vacuoles. Those distinctive endothelial cells have been described as having a cobblestone appearance. In addition, a perivascular and interstitial infiltrate composed of lymphocytes and eosinophils is present. Eosinophils typically comprise 5 to 15% of the infiltrate. Rarely, they can account for 50% of the infiltrate. In the picture, you see it is a hematoxylin and eosin stained section. They are showing irregular clusters of blood vessels and intermixed lymphocytes and eosinophils in the LHE slide. Then treatment plan. Treatment is not mandatory. Intralesional corticosteroids and irradiation have been employed, but these are not very effective. Surgical removal of the lesion has demonstrated the best results, but sometimes they may occur. The next, developmental disturbances of oral lymphoid tissue, that is lymphoepithelial cyst. The oral lymphoepithelial cyst develops within a benign lymphoid aggregate or accessory tonsil of the oral or pharyngeal mucosa. The surface of the lesion may be indented with tonsillar crypts, as are the much larger pharyngeal tonsils of the lateral pharyngeal valve. The crypts may become obstructed by keratin or other debris, or the surface opening may become constricted during episodes of inflammatory hyperplastic responses. Certain cases develop a complete disunion of the crypt epithelium from the surface epithelium, resulting in a subepithelial cyst lined by the old crypt epithelium. This lymphoepithelial cyst was first reported by Parmentier in 1857 as hydatid cyst. Apart from head and neck region, this cyst is also found most commonly in the pancreas and testes. A similar but much larger cervical lymphoepithelial cyst or branchial cleft cyst most probably develops from entrapped salivary ductal epithelium in the lymph nodes of the lateral neck rather than from the branchial cleft. Another similar cyst, that is parotid cyst, which is found in major salivary gland, especially in AIDS patients. Clinical features. Oral lymphoepithelial cyst presents as a movable, which can be easily movable and painless, asymptomatic, submucosal nodule with a yellow or yellow-white discoloration. Sometimes it is transparent. Almost all cases are less than 0.6 cm in diameter at the time of diagnosis, which is usually during the teen age or the third decade of life. Approximately half of all the intraoral examples are found on the oral floor or the floor of the mouth, In the picture also you can see this is the floor of the mouth or the below the tongue. There is a movable mass which is present. But the lateral and ventral tongue are not uncommon sites of occurrence, nor is a soft palate, especially the mucosa above the pharyngeal tonsils. This cyst may also occur within the pharyngeal tonsils, and occasionally superficial cyst rupture to release a foul tasting, cheesy and keratinaceous material. This cyst has a clinical appearance similar to that of an epidermoid cyst or a dermoid cyst of the oral or pharyngeal mucosa. The lymphoepithelial cyst never occurs on the alveolar mucosa, hence it can be easily distinguished from a gingival cyst of adults or from an unerupted parulence or pus pocket at the terminal of a fistula that extending from the apical or lateral region of an abscessed tooth. Histopathological features, or what can you see in the microscope? The lymphoepithelial cyst is lined by atrophic, the epithelium is atrophic, and it is often degenerated stratified squamous epithelium, usually lacking retrorages. The retrorages is usually lacking or it is flat, usually demonstrating a minimal granular layer, and mostly orthokeratin is seen to be slowing from the epithelial surface into the cystic lumen, often completely filling the lumen and sometimes showing dystrophic calcification. Rarely, mucus-filled goblet cells may be seen within the superficial layer of the epithelium, and occasional cyst will demonstrate an epithelium-lined communication with the overlying mucosal surface. The cyst is entrapped within a well-demarcated aggregate of mature lymphocytes, and the aggregate or tonsil will have a variable number of germinal centers. The lymphoid aggregate may be hyperplastic. Then differential diagnosis. First is Warthin's tumor. Pathologist must differentiate this lesion or the lymphoepithelial cyst from the Warthin's tumor, that is papillary cyst adenoma lymphomatosome. This is lined by bilayered cuboidal columnar or oncocytic ductal epithelium. It is almost always found in the parotid gland. But the lymphoepithelial cyst, which is a single layer of epithelium, and there is increase in amount of lymphocytes. Another is well differentiated squamous cell carcinoma. Metastatic deposits of squamous cell carcinoma or well differentiated squamous cell carcinoma and cysts have very small lumina with degenerated epithelial linings, and it may mimic well differentiated squamous cell carcinoma. The combination of epithelial lined cyst with lymphoid aggregates is unique enough to make the diagnosis of lymphoepithelial cyst. Coming to treatment plan for lymphoepithelial cyst, no treatment is usually necessary for oral lymphoepithelial cyst unless its location is such that it is constantly being traumatized. Most lesions are removed by conservative surgical excision in order to arrive at a definitive diagnosis. There is no malignancy or malignant potential to this lesion, but the lymphoid stroma, as with all lymphoid tissues, can become involved with an extranodal lymphoma. So these are all about the developmental disturbances of oral lymphoid tissue. I hope you like this video. If you like this video, please like, share and subscribe to this channel. Thank you so much.